So, Dr. Richard Semelka has written an unconscionable number of peer-reviewed articles that are published in radiology journals and has participated in the writing of 17 textbooks in the field of radiology. One of his earliest articles was for Medscape Radiology, where he served as editor-in-chief. And one of his textbooks is a definitive text on body MRI, the MRI of the abdomen and pelvis. And I have an Amazon link for that, which I will send to Lisa. Dr. Semelka did, interestingly, a plastic surgery clerkship in Australia in 1982, followed by a surgical internship in 1983 at the University of Manitoba, where he was on the Faculty of Science and Medicine, starting in 1977. He did his radiology residency in 1984 at the University of Manitoba. He started worrying about the effect of gadolinium used for contrast MRI examinations long before anybody else became suspicious and began extensive publications. This was not an especially popular subject with the world's radiologists. He was one of the few people who actually listened to patients who suffered after receiving a gadolinium contrast MRI. And he opened a clinic in North Carolina to treat those patients suffering from what he described as gadolinium deposition disease. As early as 2007, gadolinium had been linked to a disease called nephrogenic sclerosis and was described as being very rare. Again, I have a bunch of references that I'll be happy to send to Lisa. By 2014, several papers had been published linking gadolinium exposure to renal failure and systemic sclerosis. But the conventional view at that time, and seems to remain until this day, that gadolinium is rapidly eliminated from the body and has essentially no residual effects. Until somebody named Semelka started listening to patients whom he began to see in his clinic in North Carolina. He has developed a protocol for chelation of gadolinium, which appears to be very effective if they can tolerate the immediate effects of chelation therapy. Dr. Semelka, let me turn it over to you now. And thank you for talking to us. We really appreciate it.
Well, Martha, thank you very much for that nice introduction. And I'd like to say as far as introductory comments is that perhaps the one physician group that has earliest and even before me embraced the concept that you can be sick from gadolinium and not have renal failure are integrative medicine specialists. So, I'm actually speaking to one of the rare groups that are fully on board with this. This would not be as welcoming an audience, I can assure you, if I was speaking to radiologists, which, to be honest, I consider shameful. And it to me is amazing that, and I guess we see it with a number of different drugs where physicians want to ignore what's obvious. And quite often when I introduce the concept of gadolinium deposition disease and how I'm going to organize my talk is to first talk about the diagnosis, then talk about who gets it, treatment, and then some words on prognosis. And then we can have open discussion if you have some questions you'd like to ask. But one of the things that and many of these things are kind of dark humor, but I put it this way. If you had an 8-year-old child and you told the child, I had an MR and they gave me some kind of fluid, and after I got that fluid, I felt really very sick. You told that to an 8-year-old child, the child would say, hey, you probably got that from what you just had. as opposed to what we sort of twist ourselves into thinking, well, is this ALS? Is this lupus suddenly presenting now? No. If, to me, the elements of the diagnosis are quite clear cut, and that sort of introduces the diagnosis. It's clear cut. So, regardless of what the symptoms are, if you get something and you're sick, many people are sick right away. Now, one of the problems is that people oftentimes, maybe a few days and sometimes up to a month, I consider reasonable to associate the development of this disease back to gadolinium. So the essential diagnosis is you had received gadolinium and now you're sick. So the next concept is, what are the symptoms? Now, interestingly, many of these symptoms are very similar to other diseases that no doubt many of you are very familiar with and dealing with. And I consider these all in the category of T-cell dysregulatory conditions. So perhaps most in the news right now is post-COVID syndrome or post-COVID vaccine syndrome, but all sorts of other unusual conditions that have been named, like chronic inflammatory syndrome, chronic fatigue syndrome, cytokine release syndrome, fibromyalgia itself. These are all very similar diseases. And one of the tragedies are that many people who start with these various diseases that are neurological in nature, what ends up happening to them is that they end up getting a gadolinium-enhanced MRI because they get seen by a neurologist to investigate why they have these strange neurological diseases. They get an MR with gadolinium, and then whatever they had before, now they're worse. And one of the first things I want to stop happening is that once you're alerted that the patient has reacted to gadolinium, they should never get another gadolinium injection again. Because what we've observed is that each time you do a follow-up gadolinium injection for what turns out to be gadolinium deposition disease all along, people get progressively worse. If we can stop that obtaining of gadolinium injections after the first one, a sizable number of people recover on their own with no treatment whatsoever, at least a third. It may take up to 2 years, but many people recover on their own with things that you would generally anyways do in your specialty, which is managing their nutrition, making sure they're paying attention to activity, physical activity, and maybe doing things like sometimes sauna is helpful. So just conservative treatments is sufficient for most people who have just one gadolinium injection. But unfortunately, most of the people I see, they've had 3 or 4 or 5 and up to 50. And once you get, beyond 10, I mean, it's like any other horrible disease. It's like saying, well, I'll treat somebody with kidney cancer who has a 1 centimeter tumor isolated to the kidney. Well, the cure rate is extremely high, would be over 95%. But if you have advanced renal cancer with metastases everywhere, there's essentially no cure. So that's kind of what we struggle with gadolinium deposition disease. And I hope with my education, the first thing we do is stop the repeat gadolinium injections. So these are the symptoms that I consider classic. And the one that maybe is the most different from other conditions, I think maybe because gadolinium is somewhat unique to most other metal toxicities, or maybe unique compared to most metal toxicities, is it's given directly intravenously. Most of the other metals are acquired by ingestion, sometimes by inhalation, sometimes by excess skin contact. But gadolinium is given right into the veins, and that's why many people complain of one of the principal symptoms, and I'll go over the top 4, but I'll talk about many of the others, is burning skin pain. And when we say burning skin pain, it's not like, I feel a little bit warm. It's like you feel like you're on fire. And the other thing is, again, because it's administered systemically by the veins, many people talk of deep body burning, intense body burning. And I think that's different from most of the other conditions. And I think it's because they got the gadolinium by IV route. So burning skin pain, boring bone and joint pain. So when I say boring, people describe it like they've been stabbed with a screwdriver in any of the bones in your body. Perhaps the most distinctive is ribs. And the explanation for that, for ribs, is that is the group of bones that maintain red marrow through adult life. And this is a reaction, as I said, from immune cells. And my theory is that they're T cells that line up everywhere. So rib pain is very distinctive, but it can be any pain that they suddenly get intense pain. The third thing that people complain about is muscle fasciculations. Oftentimes, we call it muscle twitching. 4 is brain fog. So those round out the big 4 that the vast majority of people have: burning skin pain, boring bone pain, muscle fasciculations, brain fog. But then as we're learning more and more about post-COVID vaccine and post-COVID, since it's systemic, all organ systems are involved. So the other common things are individuals frequently complain about imbalance. I don't know how much of that may be cerebellar, how much is peripheral nerve. I suspect it's a combination of all of the nervous system. Visual disturbance is very common, of all forms of visual disturbance: cardiac arrhythmias, GI disturbance, and generally they're hypomotility, so entities like gastroparesis, and head pain. And I use the term head pain and not headache because they say it's a pain that they've never had before. They've had headaches before, but not like this. And the way sufferers have described it, it's like having a swimming cap put on your head, but it's 4 sizes too small. So it's this constricting pain over their head, different than any other headache that they've ever had before. So that's basically the association. Shortly after they get gadolinium, those are the symptoms that are most common. So the next question is, who gets it? Now, not surprisingly, it's not so dissimilar from autoimmune diseases. And I consider this in the family of autoimmune diseases. And the larger category of these are called immune-mediated inflammatory diseases. So gadolinium toxicity, and I think also the other heavy metal toxicities, all fit into an immune reaction that you have developed to this metal. Now, the problem is that and many people start with they start with a very intense immune system. And many people say, well, they're never sick, never got a flu. My family got flu. I would never get flu. Their immune system is so powerful that when they recognize gadolinium, they keep on shooting cytokines at it as if to kill it. But it's like kryptonite to Superman. You can't kill gadolinium. So they have a constant low-level cytokine storm to the presence of gadolinium. Now, so the individuals who are most likely to get it are white females in the age range of approximately 18 to 45, which again, 18 to 55, but certainly beyond that in both directions. The next most common group would be white men with the same. So it's very similar to autoimmune diseases, where it's quite often 2 to 1 or more females to males. So the people to be concerned about are white females, but then you add in complicating factors, and the complicating factors will again address when we talk about treatment, because it means that treatment will require lengthier treatment and probably ancillary treatments as well. And I know Martha has a number of patients that she has on ancillary treatments to deal with not only gadolinium, but many people have started with some other immune-based disease before they got the gadolinium. So we not only have to deal with gadolinium deposition disease, but we have to deal with whatever they had also before, which more and more will be post-COVID and post-COVID vaccine syndromes. So complication factors are probably number one and most common, that sort of nebulous group of of um, of multiple chemical sensitivity syndrome. So you could expand that into any number of areas, including sensitivities to other things like RF energy. So multiple chemical sensitivity syndrome. People who've complained, I was sensitive all my life to different chemicals and drugs, couldn't take them. They are putting at higher risk. So when I use in general terms that maybe 1 in 10,000 people who undergo gadolinium injection will get this disease, if we look at white females, it's then about 1 in 7,000. But as you add in complicating factors, you ratchet up the likelihood till you get the more complicating factors you get, then you're now in the range of 1 in 50 or more likely. So other complicating factors are maybe self-evident. So taking drugs that alter the immune system, and perhaps the most common is high potency antibiotics. So people with white females sensitive to chemicals, they're taking high potency antibiotics before getting gadolinium. Suddenly you're in the range of 1 in 1,000 or less. Other drugs that alter the immune system, whatever, put them at higher risk for getting this disease. And then massive injuries, injury to your microbiome, all of these things are complicating factors that make you have more severe disease and require more treatment, as we'll get to in a moment. And I think another category related is quite a few people who've had major surgery of whatever kind. And again, I think it's the effect on the immune system. And the way I like to think of it is this. If you imagine that your immune cells have to deal with all kinds of insults constantly, maybe at least 1,000 a day or many more of aberrant cells they have to kill or infective organisms, your immune system works basically oftentimes with a few steps getting to the point of dealing with the injury. So you can imagine if you're doing that at baseline, but then suddenly you're hit with taking high potency antibiotics. So we're expecting our immune system to recognize that although gadolinium is foreign, it shouldn't try to kill it because it'll only kill you. If we expect our immune system, suddenly it's like you're in a tornado. You put your immune system in a tornado and you think, well, geez, yeah, you still recognize using 4 different steps, you still recognize that gadolinium is something not to react to. So the more things that you stress your body, the more likely you're going to get sick. And many of them are also quite simple. So people should be well hydrated. And some people also describe that they went on a marathon within a couple of days or before or after. So anything that can affect your immune system, you have to avoid. So if you have patients that are unavoidable to get gadolinium, you have to tell them you can't be doing these things. And you also have to recognize what the risks are so that you may think, well, maybe you need to do something else. And I must admit, historically, as a radiologist who's a specialist in MR and specialist in gadolinium, said, well, you need to have a gadolinium enhanced MR. But more and more, I default to the fact of a couple of things. Number one, maybe you don't need any imaging whatsoever, because all of you are also well aware that at least a third of all imaging studies, at least a third, are never indicated. So maybe you don't need imaging. And if you need imaging, there are alternatives. It's not just you get gadolinium and MR or nothing. And one of the things that I have objected to, I find it shameful, speaking to patients who've underwent gadolinium enhanced MRI, how they've been bullied both by their physicians and by the imaging center, saying, if you don't get gadolinium, we're not going to do it. So neurologists saying, if you don't get a gadolinium enhancement of the brain, we're not going to do it. So as if to say, well, we're going to let you die, or the imaging center, we're not going to do it if you don't get gadolinium. And I tell individuals, for instance, who contact me before getting an imaging study, I tell them, it's your decision. Don't be bullied into it. And if they won't do it without gadolinium, well, there's more than one imaging center. Go to somewhere else, because you can get answers obviously without gadolinium. But the caveat that I tell them is that rarely you can have an extremely serious disease and the gadolinium would have helped make that diagnosis. But it's relatively uncommon, but it does exist. So you have to accept that possibility if you reject gadolinium. In my case, I oftentimes would, well, I actually have had 13 gadolinium injections myself, and I'll talk about treatment in a minute where it comes into this. So the funny thing about that, and most of those gadolinium enhancements actually were to test on myself to see if there were acute side effects from the drug, because at the time, this would have been in the years from, well, from the years of 1992 through to 2006. I would have been using myself as a study patient, both for agents and for new sequences. So over the course of those years, I received 15 gadolinium injections, and including basically all the MR contrast agents, because I was looking for acute side effects and I didn't want to test it on patients. And at the time, I thought we were all instructed that it's as safe as water. So the bad news is I have 15 gadolinium injections in me. The good news is I can use myself now as a normal for all of our studies. Because one of the things I want to get to in a moment is there's an incredible opportunity to understand all forms of disease, particularly autoimmune diseases, by studying both gadolinium deposition disease and the treatment of chelation. Because with chelation, you're actually initiating right at that time, at time zero, you're initiating a reaction of your immune system. And we've now published in major radiology journals 3 papers on cytokines, both patients with disease and also comparing with normals. And I was one of the normals. I had assumed in the study that we did, where we looked at patients who had just one gadolinium injection and had relatively severe GDD within 3 months to a year, so they would have maximum immune response to gadolinium. And myself, at the time, the first time I did this, I thought, well, I've not been sick from gadolinium. I have 15 gadolinium in me, so I mustn't react at all. I should have no cytokine response. And people who have tremendous GDD with one, and it's within, a year of getting gadolinium, they must have a tremendous cytokine response. It turned out that looking at total cytokines, and unfortunately, we had too few numbers at this point to really distinguish between disease and non-disease. But of all individuals, I had by far the greatest cytokine response. And the reason for that, as I thought there'd be no cytokine response. The reason is, of course, as you know, there is something in the neighborhood of 140 different cytokines. So most of my cytokines would be regulatory cytokines that prevent, also termed T suppressor cytokines, that suppress reaction. In addition, I think that they are communicating cytokines to tell all the other cells in your body not to react to it. There's something weird in your body, don't react to it. In distinction, people who have GDD and also NSF with renal failure, they have much more pro-inflammatory cytokines. So even though their peak was low, total peak of cytokines, the amount of pro-inflammatory cytokines would have been the dominant species. Maybe 90% would be inflammatory cytokines. And I estimate probably in myself, 5% would be inflammatory, 80% would be suppressor. And I think that there's a category of communicating cytokines that I think also I have in my system. So the point is, when I tell people, like people opposed to this, radiologists, company people, this is an incredible opportunity to understand cytokines. because with no other condition do we get, and except you could also do this with vaccines, and that's what I would recommend. For $1 billion looking at COVID, why nobody looked at the cytokine response? Because that's another situation that you give instantaneously. When you've given the immune challenge, look at the difference between people who eventually develop post-vaccine syndrome from everybody else. That would answer so many questions. So this is an ideal scenario to understand autoimmune diseases, by understanding the difference between the majority of people who are like myself, who don't react, from the minority that do react. So that leads us to the next category of treatment. Now, there's basically three forms of treatment that you could consider treatment, one of which is avoiding getting it. So that's why, for me, the first treatment is never get another gadolinium injection again if you think you have GDD. It's the simplest and most obvious. Never get it again. That would take care of more than 50% of the sufferers. The next treatment that we all use, and it's a little bit it's still a work in progress, is understanding how to detoxify people. And at this point in time, I recommend, and I think probably a number of you are using various forms of standard detoxification methods, which I think is the wise thing to do. I think it's an area of development, understanding what will be the most effective. I have things that I recommend people. I like turmeric and quercetin. I like that combination. I like chlorella and spirulina. These are anti-inflammatories that people have responded well to. But in the meantime, maybe the simplest thing is, as I read the literature on COVID and COVID vaccines, at the bottom of the description of treatment of disease, invariably they say, well, with new COVID variants, the vaccines actually may make things even worse. The final paragraph is healthy diet. So healthy diet with just containing things that are known to be anti-inflammatory, that are antioxidants. Just a healthy diet works for these people, as it does really for probably all of us. Should be on a diet like that. And that's, to me, what, as far as I go generally with detoxification. Now, I'm in a different position from everybody else with this, because I've written all the papers, or the majority of the papers, not all of them. Thankfully, there are more and more different groups that have the courage now to write about it. None of them are radiologists yet. But and that's important, that there's generalization in the literature. But because of the fact that I've written most of the papers, I estimate there's probably 100 attorneys working for the pharmaceutical companies looking everything that I do to identify, hey, this guy is crazy, because he's recommending them doing niacin and sauna or whatever. So I really have to follow a very strict recommendation, because everything I do. So that's why I rely on people like yourselves to let me know things that are very useful, because these are things that I can't experiment on my own, because I will jeopardize my position, and hence the credibility of the disease to begin with. So I just have to be very cautious. So our treatment that we use basically follows the principle that MR radiologists understood for a number of years and refined our understanding, that with gadolinium-based contrast agents, the best agents have the highest thermodynamic, which is the same thing as kinetic stability. So the best agents are the macrocyclics, Dotarem, Prohance, because they have the highest stability. So as I now put in my blogs to radiologists who dispute this concept, basically what I'm doing is recreating a gadolinium contrast agent in the body using exactly the same principles that have been so critical in understanding what makes a gadolinium agent useful. So, for example, agents that I don't use are agents that in the 1980s they looked at as potential gadolinium ligands, gadolinium MR contrast ligands, but the stability wasn't strong enough. So EDTA was one of the drugs that was used, but it wasn't stable enough. So I don't use or recommend, and again, that's something, well, first of all, I wouldn't anyways, but anything that looks like I'm a little bit nutty, I want to avoid doing. So I use the most stable available chelator, which is DTPA. And just to give you numbers, these are approximate numbers because I didn't look at them again before giving this talk. But the approximate stability of EDTA with gadolinium is 17. And these are logarithmic numbers. The approximate of DMSA is something like 12 or 13. For DTPA, it's 22. So each one of those digits is a factor of 10. So DTPA is 300,000 times more stable with gadolinium than EDTA. So from my point of view, why would you use something that's less stable? Because that will then be subject to more redistribution, because I use the term redistribution, or this is the common use of redistribution is the picking up of gadolinium from tissues and re-releasing it right away. That's redistribution. That happens right away after giving the chelator. Re-equilibration is something that occurs in force at around 3 weeks post-chelation, and that's why a number of people who are on schedules like every 4 weeks getting DTPA, which a number of my patients historically have been on, the last week, that fourth week before chelation, they get their symptoms coming back. And although many people sort of panic at this concept, including, I think, practitioners, in fact, to me, it's a very critical feature to show that the patient has gadolinium deposition disease and not what I am, which is gadolinium storage condition. If they don't have the initial flare to an effective chelator, which I call gadolinium removal flare, that starts anytime from immediately to 2 days after. If they don't have that, they don't have gadolinium deposition disease. And even more specific, I think, is at 3 weeks developing re-equilibration. And that's using the principle of Le Chatelier's principle that everything strives to be in equilibrium. So the chelator can get, and it regardless of whatever chelator, however potent the chelator is, the tissues that bind gadolinium less tightly are easier to remove from. So when we chelate, most of the gadolinium is coming out of skin and then the soft tissue organs, including the brain. Very little, although DTPA is powerful enough, it uniquely can also pull GAD directly from bone, but not that much. So what Le Chatelier's principle is, and I'll just use my hands as an example. The two largest reservoirs are skin and bone, something like this. So if we take gadolinium out of the skin and drop it down there, now we're not in equilibrium. So what happens is that gadolinium moves from bone back to skin to get back into re-equilibration. And that starts occurring in force at around 3 weeks. So at 3 weeks, people start complaining. They think, oh my God, this has all been a waste. Now I'm sick again. I'm sick like I was before. And I say, no, you actually are showing re-equilibration flare. And that means you have the disease. You don't have like ALS or you don't have lupus. You have definitively GAD. And if it's a big problem, the simple thing to do is to shorten the intervals. So some people I know will be a problem because they've had like 10 or more gadolinium injections. I tell them, we probably have to do you with weekly chelation. You could argue, well, why would you want any amount of re-equilibration that people get symptomatic? From my perspective, that they can tolerate it, it's the best way to get gadolinium out of bone. So the other critical thing to think about with chelation is you actually ultimately want to reduce the total gadolinium body content. This would also be exactly the same with lead. What we're doing with gadolinium is identical with lead. Gadolinium DTPA is also not to the same extent, but it's more powerful than EDTA as far as removing lead. So the good news is that since everybody has lead in their body, we're getting lead out all the time when we do gadolinium chelation. And these metals no doubt interact with each other. So what we do then is we want to control the flare. So the two ways to do it, and I use the standard approach that is used for acute hypersensitivity reactions, and maybe 10 million doses of acute hypersensitivity reaction have been done for cancer drugs, for radiology drugs, for all sorts of drugs that have a high incidence of acute hypersensitivity reaction. We use the standard approach, which is steroids and antihistamines. So that's what we use to control flare. And if you say, well, that patient's not flaring, well, there's two possibilities. Either they don't have the disease, or you haven't used a chelator that's removing any gadolinium or doing anything. Then you have no flare. Everyone has to have flare. Now it can be managed, and I use steroids and antihistamines, and eventually cutting down on that. And that's part of the art. I oftentimes now start with lower amount of chelator and move up, and I start with a higher amount of steroid and antihistamine and move down, because ultimately I don't want them to be on long-term high dose steroids, because as all of you are very acquainted with, steroids can be as bad as anything else that we do to patients. So I try to keep the steroids as low as possible. And also that's why I call our use of steroids frame, that I want the use of steroids just framed around the injection of the chelator, starting either the day before, sometimes I say 2 days before, and going maybe 5 to 7 days later. But I also tell patients, initially when I did all of this, I did it everybody the same. I tell patients, you are the person who decides everything. You decide if you're managing the flare, you're deciding the intervals between chelation, and you're deciding when to stop. So the flare is too strong, the two options are less chelator or increase the steroids and antihistamines. If there's too much reequilibration flare, then you shorten the interval in between. Generally, the flares get less severe as time goes on, and of course that would make sense, because the more gadolinium you have removed, the less there is the impetus for creating a flare, because there's less gadolinium in the body that's moving. So with time, the flares are lesser, and I always encourage people, go with less steroids if you can manage. If you can't, don't panic, because one of the things that I learned from actually watching centers before I started chelation, and me speaking to them, is that without the use of steroids, a number of people, the flares are out of control. And you can also understand why that could be the case, because and they'll say this is as bad or worse when I've got gadolinium deposition to begin with. And this is the explanation. Again, all of these things make scientific sense. If you think about it, what's happened is you've injected gadolinium, the dendritic cells picking up the gadolinium, going to lymph nodes, showing T cells. What do you think about this? What do you think? T cells, in most people, say forget about it. People who are going to have the propensity for GDD will say, oh, this is something foreign. We have to react to it. They then go to the tissues, become tissue resident memory T cells, and replicate. So initially, when you first get the gadolinium, and these are numbers that are probably off by many factors, but it's the concept. Maybe there is 1 million T cells that are reacting initially, but once they've started replicating beyond a month, now you've gone from 1 million to 100 million T cells that react to gadolinium. So when you remobilize gadolinium, it's not 1 million cells that are reacting, it's 100 million cells. So that's why the flare can be, and patients can be right, it can be worse. And then what I don't want practitioners to think, oh my God, what have I done? It's not even worse. They're saying it's worse. It's worse because they have simply more. It's not because you've done anything wrong. You've done the right treatment. It's just you have to manage it by either starting with low chelator, which is what I do, start with low amount, higher, including IV steroids, and then an oral steroid envelope around it, and then work up their tolerance with chelator, usually that first, and then drop down the steroids according to their tolerance. And then, how many chelations do they need? What I've observed now over the years, if it's simple GDD, and that is basically, they had maybe they had something like a small meningioma, or they had like a a knee injury and got gadolinium because they were thinking of an abscess or something, but no multiple chemical sensitivity syndrome, no chronic fatigue, no major surgery. It's basically 5 chelations with DTPA spaced something like 3 weeks apart, simple GDD. They're fine. Now, they will always there will always have, and that's why I now call it not a cure, but a near cure. And I tell people, think of it like it's either like herpes or the varicella virus. You know, you'll basically, and particularly maybe with the varicella, where the recurrences of getting shingles is really quite rare. You will, through the course of your life, there will be periods that you will flare again from gadolinium, but we can manage them. First of all, most of them will probably go away on their own. And if they don't, we can chelate you again. So I try to tell people not to panic. So it's not unusual, for instance, that we'll do 5 chelations on somebody. They're doing perfectly fine. Then a year later, the symptoms creep back. They think, oh boy, my symptoms are coming back. I tell them, no problem, come back, we'll chelate you again. And that's an unusual occurrence that we do it in that fashion. Now, as they get more complicating factors, particularly complicated surgery, multiple chemical sensitivities, then it's no longer 5 chelations per gadolinium injection. Then it's an uncertain number. Hopefully, I don't like, personally, I don't like to see people going beyond 100 chelations. Personally, most of my patients, I'll try to keep less than 20. But more and more, actually, nowadays, I try to stick with less complicated people, because what you will find, people are more complicated, is they email you constantly. So I have a few patients who email me daily. And now I actually tell people, who seem to be very sick, I tell them, I can manage you, but I don't want to. But I tell them I can, and I can improve you, but I don't know how much better I can get you. And maybe you should stay somewhere closer to where you live, and I'll help with that. Because as I said, it's funny, as a radiologist, and that's one of the problems with radiologists, no patient contact. Now suddenly I have maximum patient contact, which is sort of funny. And just as an aside, my father was an anesthesiologist for most of his career, but the last 10 years, he was one of the pioneers in chronic pain management in Canada. So it's kind of funny that I've followed a similar course of doing something with no patient management contact, and now suddenly I have major patient management. And I'll tell you, it's actually, I must admit, and you will find this yourselves if you haven't started yet treating patients, is that people are so appreciative, and it starts from the very beginning. If you're the first medical practitioner that tells them, "I believe you," that right there, that placebo effect is probably 10 to 20% of getting them better, because you will be the first. And to me, it actually, and it makes me angry, but I have to keep blinders on. And Martha, you probably have heard a number of these stories as well. I have patients who've been kicked out of doctors' offices and told not to come back, and horribly mistreated by so many physicians. And it's a shameful embarrassment to me to think that that's happening to patients. But so that's the standard treatment, is DTPA. Now, an interesting idea is, what about multiple heavy metal deposition disease? Well, if it's GAD and lead, this is also a great combination, but this is a work in progress, and something also that some of you, I would like, the input on, for instance, a combination of different chelators and seeing how that works out. One of the beautiful things, though, about how we test for heavy metals and for treatment is there's very few things in medicine that have such direct results. So what we do routinely, and I try to do it, get them to do it 2 or 3 days before chelation, 24-hour urine for heavy metals. Now, I happen to use doctor's data. Genova also looks at a panel of metals. I kind of like looking at the amount of metals per 24 hours because that kind of is easy and makes sense to me. Don't like the fact that Genova quite often does it as a metal, amount of metal per gram creatinine. Then I have to figure out, okay, well, what could be happening with their creatinine? I just want to know how much metal is coming out 24 hours. And then after the chelator, about an hour after the chelation, so the first urine, hopefully, the end of chelation, some people want to go to the, urinate in the middle of chelation, which is fine. But after that first chelation, I get them to collect for about 24 hours, which is, to the next day when they come for chelation. Maybe ends up being 23 hours, but that's close enough to 24 hours. And then you can see what the native elimination is of metals. And then you can see how much more metals are removed by DTPA. That works for any chelator. And if they flare, then they're also sick from it. So that's what I look at. I look for gadolinium going up a lot. Lead always goes up a lot as well. And I look for them to have some kind of flare to tell me I'm doing the right thing. So right now, this seems to me the best treatment. Now, maybe other of the ligands that are used in MR contrast may be a little bit better. Maybe BOPTA, which is the ligand for multi-HANTS, it has a higher stability constant. But I'm sure many of you are aware of the work on oral agents, and the one that's perhaps most discussed is HOPO. And to me, that's probably a major breakthrough, kind of waiting until it gets FDA approved before speaking too highly about it, but also can't ignore the fact a number of people are taking HOPO, and in my position, I can't ignore them or reject them. So I speak to them, but I never will directly tell people to take HOPO. Sometimes I may tell people if I was exactly in your situation, I would consider HOPO, but I'm not telling you to do that. I'm telling you what I would do if I was exactly in your situation. So I have, patients that have no money. And that to me is, one of the other disgraces of the US healthcare system is that we don't have universal healthcare coverage. And as those of you who see these patients, and Martha would be certainly one of them, you realize that a lot of the people, they don't have any money. So the reason why they're lying in bed in their home in intense agony 24 hours a day is because there's no money available to them to pay for chelation, because it is expensive. The agent is expensive, and we use, certainly for the first several chelations, we do use IV solumedrol. Everything's expensive. So, it's an expensive procedure. It just simply is. And just to give you numbers that we use, because that may be guidance for what you would be looking at paying for. Now, the agent itself is about $80. If you use solumedrol, that's $25, and then all the other equipment and everything else. So we charge $1,000 for 2-day chelation. If I don't use solumedrol, we drop it down to $900. And for 1 day, it's $500 and $450. So yes, it's expensive, but I tell people, well, it's your life, and I'm sorry. I can't charge less than I do, because this is all I do. I'm not a physician who's seeing people with sore ankles. I can get in and out in 5 minutes. I have just these people, and I don't blame them. They're very time consuming. A number of them are very time consuming. So that's what I charge. Now, the future, I think for all of us and for all heavy metals, because I think we grossly underestimate the number of people who are toxic from heavy metals. And I'm talking about all of healthcare. I think it's a much higher. So when I say that the numbers for gadolinium are 1 in 10,000, it's probably higher. I say the same is probably true of lead. Everyone has lead in it. So every patient who we've done urines on, including normals, everyone has lead. So everyone has lead in them. And I say, well, probably the numbers are similar. It's 1 in 10,000 that are actually sick from lead. And rather than, no, it's lead toxicity, but I tell them it's basically lead deposition disease. So, but is it that low? I can't help but think, how much of depression, because as you read the toxicities of all the heavy metals, depression is high on the list. And if we think of how depressed we are as a society, we have to think, well, how much is the heavy metal taking a role in that? So I'm just going to finish with actually, I've seen I've almost consumed the hour. The prognosis, simple GDD, near cure in everyone, particularly if it's 1 to 3 chelations. At most, they would require 15 chelation sessions spaced 1 to 4 weeks apart. That's near cure. Now, not many people are near cure. Many people have multiple chemical sensitivity syndrome. That maybe doubles it, but I always tell people, you decide when to stop. You stop when you feel like you're 80% back to where you were, and we'll see how bad the re-equilibration flare becomes starting at 3 weeks and going to 3 months. Because once we've gotten a lot of gadolinium out of people, there is the tendency for all of us for our systems to calm down. Now, it may take a couple of years, but I want to undertreat a little bit rather than overtreat. So I tell people, once, and the other thing I look for their symptoms when they tell me they're 80% better. And the other thing I look for is that most people, if they're around 1 year post gadolinium injection, we chelate. Quite often numbers are typically in the range of 30 micrograms per 24 hours, which is somewhere in the mid-red range of doctors' data, and Genova does it similarly. I wait till things get in the low to mid-yellow range, so 3 to 5 micrograms, to think the urine values are not a lever that, let us start thinking about, can we stop chelation? And, if we pause and your symptoms rush back, don't panic. Just means we've stopped too early when there was still too much more gadolinium. And I say also, besides that, because we waited in time, now a lot of gadolinium has moved from your bone back to your soft tissues, where we'll get a lot out. So it's not a wasted venture. In fact, these longer pauses can be useful because it helps us reduce your total body gadolinium content. And I think with that, that's a good stopping point. And I guess it allows maybe a few minutes for any questions, but I see I've consumed the full hour. Thank you for your attention.
So thank you so much. Do you have time for some questions?
Sure, I'll take some questions.
Does anybody have any questions?
Yeah, yeah, this is Dr. Radoff. I have a question, but it's from Martha. Martha, now, I don't do the chelation anymore. Are you going to do this kind of DPTA chelation if I refer a patient to you?
It would depend on what the metals were. If it was gadolinium, yeah, I would do DTPA. Otherwise, I would keep going with EDTA, DMPS if it was lead mercury.
Okay, thanks. I have another question too, Dr. Semelka. You started talking about some of the situations that I use, like turmeric, other anti-inflammatories, chlorella, and some of the others that you mentioned. How effective is that compared to chelation? It seems to me it can't be that effective, but I just wonder what your experience is.
Well, that is actually an excellent question. Many people who've come to me have already been on, many people read, go on the internet and read and take, some of them take like an enormous list of supplements, and they're still sick. So I think though, if it's just one gadolinium injection, and they have fairly simple gadolinium deposition disease, a trial of doing just anti-inflammatories and antioxidants is not at all a bad idea, because I think a number of people will do better. And my view is that a lot of these things may contribute anywhere from 1 to 5% of improvement. But I tell, my patients, I'll take that. Any percent improvement that we'll get from any of these things, we'll take. Anything that helps their condition, we should do.
Yeah.
So I don't discourage them from taking certain central core things, and certainly, foods that have many of the important either minerals or antioxidants, anti-inflammatories. I encourage them to, vegetables, and I like to emphasize broccoli. And I also tell them one of the things that we have to pay attention to in the modern age is that things that are supposed to be healthy may turn out to be not healthy because of pollution. The best example of that for me is kale. So I tell people of that family, the one that tends to accumulate the least amount of cesium and thallium is broccoli. And there's so many other positive effects that don't eat kale, but eat broccoli. That should be your vegetable in that family of group. But so I recommend them to eat a number of different things, like things that I'm sure that you would recommend as part of the healthy diet. I don't think they are on their own powerful enough to, especially people who I'd say have fairly bad GDD, fairly symptomatic, but I think that's always an important component to it.
Now, I imagine you don't do medical legal work, do you? You do expert testimony?
Well, I don't like to, but I do some, and for instance, people who've come to me as patients, and depending on how badly they've been treated by whatever group and I oftentimes, to be honest, I don't like to speak against radiologists or physicians, but in some of these stories, I have told people I would be your medical expert. Because this is just too egregious what's happened to you.
Mhm.
So I do, but it's not something, some people like it. I don't like it. It's never pleasant. It's never a happy story. It's always horrible,
Yeah.
but I do
Okay.
medical expert work.
Because I've seen some gadolinium patients, and I'm no expert the way you are, and I told them point blank, you don't want me to go to bat for you as an expert for gadolinium deposition disease. But I've got someone coming in from another state, and I don't know exactly what they've done or what they haven't done. But if I hate the legals, but if they're good people and they want and it's a legit case, would you consider looking over the data and taking their case, or should I not bother you?
Well, if as you described, as you say, if you're considering them good, earnest people and they've been badly treated, yeah, I would look at the case. And I'm actually, as along the lines of your earlier question to Martha, that I could see maybe that we will be in some sort of, maybe with us, there's some sort of triangle discussion of not only care of patients, but other things as well. So Martha and I do work together on some patients. So for instance, if you're not comfortable in chelation or want to send, so for instance, what I do with most patients, to be honest, who come to me, because it's sufficiently rare that they come from some distance, I tell them, I'd like to see you for the first couple of chelations, but it's expensive. And then with the travel and so on, it makes it really expensive. But I'll help you find a place closer to home. So I think a certain number of my patients certainly, have gone Martha's way, because I recognize, it's to come this distance and all the hassle and so on, it's much better if you can go closer to home. So with the nonprofit GAD track, we do list different centers around the country and around the world where people can go to. But, I quite often like to see, unless I know that they're going to go to somebody with expertise, then I said, if they're in Arizona, I just say, go see Martha. But if I don't know the people in a certain area, like North Dakota or Missouri or Michigan, I tell them, listen, I'd like to see you for the first couple of treatments. Make sure you have the disease. Make sure we're on a treatment. When you find somebody, and I tell them, listen, the people to look for in your community are integrative medicine specialists, because these are the one group who are going to be receptive to you. I will work with them and to get you treated close to home. So I do. A lot of my patients end up in that sort of situation. But I like the idea of, with a number of people in Arizona and the surrounding area, that we form a triangle of communication, because I don't know if Martha would want to be an expert, but I certainly, with some people, am prepared to be a medical expert. And I hate to say this as well about physicians and companies, but I'm disappointed, because I'm thinking, before all this started, as Martha introduced, I hate to admit this to patients, I probably have written more on the value of gadolinium and MR than anyone else. I don't think anybody has written as much as I have. So I had naturally thought, if a person with my credentials then start writing peer-reviewed articles, that it can be dangerous in some people, I thought 6 months, everybody will recognize it. But I didn't recognize the importance of money in the story. And unfortunately, I've written 15 major papers and some other papers on this. Usually it takes like 5 papers and things get generally accepted. And I'm just surprised that the radiology community still, and maybe neurology, still dig their heels in. But I hate to say it, but what would change their mind is legal suits.
Well,
Suddenly
I
they
think
get,
that
then they start paying attention. And I hate to say it, but that's just human nature.
I think using a team approach is good. Like someone's in the ICU, you've got a cardiologist, a surgeon, or whatever. And this is kind of like ICU medicine, because these people aren't getting better. And I've cross-treated with Martha, and I referred to Martha. And, Martha's one of my go-to people when I need, some real good advice and background. And I think it's a good idea to get people involved. It's
Yeah.
just that most
Yes.
people's ego won't let them do it, which is a shame.
Right. Right. Yes, I agree.
No. Well, Martha, I'm going to refer to this patient when she comes in for the chelation. I'm going to do some of the stuff with some of the supplements and maybe a couple of homeopathic IVs, but that could prepare her perhaps for a better result from your chelation. But that's what I think really needs to be done. There's so much knowledge of doctors in Arizona with integrative medicine compared to most states. And we sort of
Mm.
all know each other. And I think it's really helpful to say, hey, listen, you know what? Hey, Martha, give me a hand with this case. It works,
Yeah.
and she does.
Well, that's perfect.
Okay, Dr. Radoff, thank you. Dr. Semelka, before we log off, Dr. Grout had a couple questions in the chat. Are you able to see them and just quickly comment on them?
Or maybe since she's on, can she
Or
just
I'll read them out loud, okay?
ask the questions to me, and then I'll.
Is there any specific antibody to gadolinium that could be measured? And, I'm thinking that something like alpha galactose that is found in patients with Lyme disease who suddenly can't eat red meat. I just wondered if
Right.
there was
Right.
anything similar.
Martha, not that I know of, and this is actually one of the other things that, that I'm hoping by writing on this, that will get people who are experts in these areas to
To
look at it.
actually
So for
look at it,
instance,
yeah.
I'm convinced that there's a gene, because as I think you also test for, but maybe a quarter of patients have the MTHFR gene variant. I think that there may be a cluster of genes. That certainly is part of it, but it's not the sole thing because MTHFR does a lot of different things. But I think this is a genetic disease. But it's interesting, and there probably is markers, but it needs to have, people who are experts in hematology and similar.
Which MTHFR abnormality is there? Which one? There's two of them.
Yeah, I've just grouped them together, and again, it's something that probably should be defined better. But these are all things that are foreign to me, and one of the things that I've learned over the years to rely on is actually people who are experts in this area. Because one of the things that makes me frustrated with major radiology meetings nowadays is that when they have experts on safety of MR and contrast agents, the people they select are people who do MR with contrast agents and are sponsored by companies. So as I tell them, if you don't know about gadolinium deposition, you really don't know about safety of gadolinium. But the experts that are oftentimes used don't really know anything. And I've learned over the years that you have to speak to the experts and find experts who know this stuff, because, as a radiologist, for instance, I wouldn't have been an expert in chelation. So I initially worked extensively with our chair of one of the chairs of pharmacy of I forget what molecular pharmacy, Michael J., who worked himself on an oral chelator, who really understands the concept of chelation. So I didn't just dream up, all these things on my own. I relied on getting teaching from experts. And that's why I'd love to get teaching from people who understand about antibodies and various immune cells to look into this question.
Well, doctor,
and I think it wouldn't be that difficult
for many
for
years,
people.
for many years, I specialized in autistic kids, and we always check with the MTHFR gene, the COMT gene. And I just wondered if anyone is using injectable hydroxy B12 or methyl B12, because often in the chemistry of things, that helps the children. I just wondered if it would help some of the gadolinium. I don't know if anyone's ever talked to you about that.
No.
Yeah.
And that's what I'd like to discussions like this. This is how I
Yeah.
learn about things to consider. So thank you.
You're welcome.
So there is a lab that does T-cell tests for Lyme disease, and I've blocked out the name of it. It's a German guy who's running it. And I wonder whether there is a T-cell test for gadolinium, like a T-cell activation test.
That would be, I think, yeah, maybe you may not, at the spur of the moment, it may not come to your mind, but maybe over the next weeks.
I'll
It would be
remember
interesting.
and I'll let you know. Yeah.
Yeah, that would be wonderful.
Fritz, France, yeah. And do you have a list of cytokines that could be realistically measured without, costing an arm and a leg?
Well, again, I don't know the cost of them, but it seems to me that the cytokines that I had sort of initially had thought, maybe naively, that TNF alpha would be very high, but I don't think it's that's a major player. I think IL-4, IL-6 seem to be more consistently involved. But again, I would certainly like to and that's the other thing. When we did the cytokine studies, I wasn't doing it on my own. I wasn't doing it with somebody in Eastern Carolina University. We worked with Stanford Immunology Center. So with people who are real experts, because that's what we need, to look at, what kind of T cell description is involved with GDD. So, I'm keen to find that out, keen to find out people who do gene discovery to look for the gene, because a number of people I work with think, well, I've been gene tested and I don't have, none of the genes were positive. I'm thinking, well, no, I don't want to look at existing known genes. I want to have a company that can do gene discovery.
Yeah.
So, Dr. Semelka, thank you so much for this very, very informative talk. I know you're on the East Coast where it's 3 hours later, and I want us to be real respectful of your time. Would you be willing
Thank
to
you.
come back with us and maybe have a dialogue with a little bit more time for Q&A?
I guess at some point, yeah. This is
Yeah.
like a very busy period for me, but maybe in a few months, something that Martha can, yeah.
Yeah. I mean, definitely working with your schedule. I don't mean in like the next 15 minutes, but just where
Okay.
there's like a little bit more time for dialogue and Q&A, because we really appreciate you, but I also want to be respectful of your time and your time zone.
Thank you.
And thank you very
It was a
much. And
pleasure
thank
speaking to
you,
you.
everybody, for joining us this evening. I'm going to stop the recording and close the meeting. Everyone have a wonderful, wonderful night. And thank you again.
Thank you.